are listening to the Addiction Files, where we discuss evidence-based treatment, clinical pearls, and resources while striving to destigmatize the treatment of addiction in our medical culture and save lives. We are the Addiction Doctors, Dr. Darlene Petersen and Paula Cook. Welcome to the Addiction Files. We have a fantastic episode tonight. We have two guests joining us to discuss professional health programs. So we have licensed clinical social worker Kelli Jacobsen and Dr. Robert Simpson. And I'm going to turn it over to them to introduce themselves. And then we're just going to talk about what are some of the myths associated with these programs and what are some of the benefits? Who is involved? So who qualifies for these programs? How do you enter these programs? What is some of the monitoring involved and more? So I'll turn it over to you guys and let's get started.
So my name is Kelli Jacobsen and I'm the program manager of the Utah Professionals Health Program. And the Utah Professionals Health Program is a professionals health program that's been created by the Division of Professional Licensing to assist certain licensed healthcare professionals who are struggling with substance use disorder.
Great. That's awesome. We're happy to have you, Kelli. Thank you so much.
Thank you.
I'm Robert Simpson. I'm the medical director for the Utah Professionals Health Program.
Is that all you're going to give us, Dr. Simpson? Can you give us a little bit about your background? What have you done in your career?
Well, I initially trained in internal medicine, pulmonary and critical care medicine, and I was at the University of Utah and working in intensive care, primarily sleep medicine as well. And in 2011, I went and got my own substance use disorder treated, and it was a profound experience, life-changing. And after that, I retrained in addiction medicine and have worked in this field in one way or another ever since.
Wonderful. Amazing. Well, we're grateful to have you, and we're very lucky in Utah to have a professionals health program. So, my first question, and we'd love to just hear all about the whole program, but does every state in the U.S. have a program like this, or is it just dependent on state by state, and who determines whether or not a program like this exists?
I think, Kelli, correct me if I'm wrong, but I think 48 or 49 states now have professional health programs, and they're all a little bit different in terms of the professions that they serve. California is a notable exception, and I think there's one other state that doesn't have one, but most states do, and that's because there's been recognition of the importance of professional healthcare professional well-being, and that healthcare professionals, like all other people, suffer from substance use disorders and co-occurring illnesses.
Right. So tell us, what is a professionals health program for those of us who don't know? Give us a definition of what it is and why it exists, when it started, and let's go from there.
So professionals health programs are typically confidential programs that healthcare professionals can participate. Confidential meaning that the public is not aware of participation in the program, and neither is a professional licensing board. Oftentimes, PHPs are considered alternative to public discipline programs. So healthcare professionals who may be facing discipline against their license due to some sort of misconduct related to their substance use disorder can participate in a PHP as an alternative to discipline. And essentially, PHPs provide monitoring, confidential monitoring, and monitoring typically looks like evaluation, following through with any treatment recommendations, random toxicology testing, attendance at support group meetings. There's usually a requirement to have a worksite liaison, someone in the work setting, typically a supervisor who's aware of their participation in the program and can support the individual throughout the monitoring process.
Okay, that's fascinating. And so you said that it's often an alternative to disciplinary action. So I'm guessing that people get referred into it some way. So how do people get referred, and can they be self-referred? And then my third question is, which healthcare professionals qualify? Like, is it physicians and nurses? Is it beyond those kind of direct patient care professionals that extend to dentists and those professionals as well, Kelli?
And for our program, the professions that qualify for services are physicians, physician assistants, anyone who's licensed under the Nursing Act, dentists, anyone licensed under the Dental Act, which would also include dental hygienists, anyone licensed under the Pharmacy Act, podiatrists and veterinarians are eligible for the program.
Okay, that's interesting. So if anyone under the Pharmacist Act, that includes like pharmacy technicians and all the way down.
And interns, correct.
Mm-hmm.
Essentially, anybody who can prescribe substances or touches controlled substances really can participate in our program. And in terms of referrals, so people can indeed be self-referred. So they recognize, look, I've got a problem and I need to do something about it. They can call us up. I mean, initially anonymously, right? They don't have to say, you don't have to give us their name. They can just inquire. More commonly, what's happening is that people come to us because they are given an ultimatum by an employer that perhaps they've been intoxicated in the workplace, or there's been diversion of medication, and the employer says, well, look, you need to contact UPHP. And increasingly we get referrals from within the Doppel investigations. So if diversion occurs or intoxication in the workplace occurs, then the employer is actually obliged to open a Doppel investigation. And the investigations folks work with us collaboratively so that if there's a substance use disorder and there's been no patient harm that's occurred, they will refer people to us as well. We'd love for more people to come to us because they recognize they've got an issue that they need to get help with. But unfortunately, most healthcare professionals have no idea that we actually exist. And so, it's great to be with you today, and hopefully, it's part of, increasing awareness that this service does exist. And as Kelli said, the confidentiality piece and alternative to discipline, those are really big deals, because if somebody has disciplinary action taken against their license, then as a consequence of that, for a physician, for example, it can become very difficult to, they will lose board certifications, they will lose the ability to panel with insurers, to credential with hospitals. Often the DEA will take action. And so there's kind of a cascade of events that occurs that ultimately just makes it impossible really for somebody to be able to work. And we can avoid much of that. So that's an important point. And then, for people who are kind of saying, well, this is housed within Doppel, but it's not disciplinary, that's confusing too. But it's important that people know that there's really an informational firewall around our program, so that participation in our program truly is confidential.
So if somebody self-refers, which it sounds like that's quite rare, so there's not been a disciplinary action, a case opened up, and there's not been a Doppel investigation, is there mandatory reporting? Are you required to report to Doppel if somebody self-refers to your program?
No, we're not. We have a statute that allows us to accept a patient into our program in lieu of disciplinary action being taken. So we have no duty to report to Doppel or to the relevant boards.
I think that is such an important point, and I don't think that message is being given to professionals.
Right.
And I mean, I think that's why this episode's so important, that they, there's so many out there suffering that if they just knew that, hey, you can reach out confidentially, get help that's confidential, and your license can still be protected. And, how many more would seek help? That's what that's what you have to ask.
Right. Yeah, we know in, many states have had programs that have been in existence much longer than ours. And we know that over time that once these programs are known about, that healthcare professionals will utilize them. And your point is an important one, that we know that at any, over the course of a career, that the likelihood of a healthcare professional developing a substance use disorder is at least equivalent to somebody in the general population. So between 10 and 15% of people, possibly more. And so at any given time, there's a point prevalence of about 1% of healthcare professionals who will meet criteria for a substance use disorder. And in Utah right now, the number of licensees that we serve who currently hold a license would be about 70,000. And so, we would anticipate that right now there are probably between 700 and 800 who have a substance use disorder. But we have about 100 participants in our program.
Wow. So that just speaks to, in general, how many people with a substance use disorder kind of lie in the shadows, dealing with it on their own, whether or not they know how to access treatment or they want to, or there's barriers for all the reasons that we know exist and don't know exist. So those exist within healthcare professionals, and probably can be even more so because of fear of repercussions, like you've just mentioned, and stigma and shame and all those things, right?
Yeah, absolutely. Those are amplified in the populations that we serve. And so, we have dual roles, which are not only to provide advocacy and support for healthcare professionals, but also to protect public safety. And so, we know that if people are out there with substance use disorders and they progress to the point where their substance use disorder is impairing, that public safety is jeopardized. And so we have an interest in intervening earlier in the disease process, both for their benefit, but also for the benefit of the public.
So, and there's interesting data coming out now. You're both probably more aware of it than we are, but on physicians specifically, I don't know about other healthcare providers, rates of alcohol use and alcohol use disorder post-pandemic that are quite alarming, actually. Like during the pandemic, especially physicians who were over drinking and would actually meet criteria for a substance use disorder was alarmingly high. It was like 1 in 5 or something like that. So yeah, and it makes sense that you would want to intervene early to protect public safety, and then also for people to be able to get the help that they need. Robert, do medical students and residents or dental students, or anyone in the student arena, do they qualify for these programs?
Not yet. So one of the criteria for being in the program is holding a current license. But it's very much our hope that we will be able to engage with students in the future.
I think just one thing that's important to note is we talked about the variations across states and in terms of what issues they monitor and what, who they serve. And many other states do provide services to residents or medical students. And so I think it's important, whatever state you're in, to know what that resource is, what conditions they monitor, and whether it's just licensees or students, because it does vary across states.
Yeah, and I guess it's really important for states where non-licensees, have substance use disorder or pre-substance use disorder, or mild, that they know where to go. to get help. Obviously, if they can't access it through a program such, like in Utah, such as your own. One of the things I was thinking about, and I was just reflecting on my own experience as a healthcare provider, there's a lot more awareness now about burnout and provider burnout. And we have a wellness committee and we have burnout, self-scoring scales and these measures that seem to be quite well directed and well deserved. However, I don't think I've ever been surveyed other than filling out my credentialing paperwork about whether or not how I'm doing with regards to substances. I just was thinking about that. And they're never part of a burnout survey, which it seems to me they really should be, because a lot of times people are responding to professional burnout with the use of substances. Do you think that, do you think that's true, or is that just a personal thought?
There's little doubt that that's true. I think the relationship is bidirectional. The providers who are burned out are more likely to develop, to turn to substances. Alternatively, I think providers who have substance use disorders are more likely to become burned out as well, and grow disengaged and feel that the work they're doing is not important, not rewarding, and so it's a vicious cycle. But there's no doubt that they coexist.
So lead us through the process. So say that I develop or I have an existing substance use disorder that's very active, and my employer notices that I'm late to work every Monday. I'm calling in 2 Mondays a month, not making it there. And, one of my patients complains that I maybe smell of alcohol. And I get called in and I admit to my employer, say the hospital that I work for, that I'm having difficulty managing my alcohol use. And they refer me to you. What's the process from start to finish that I would go through with you?
Yeah, so the first step would be meeting with us for an intake session. And the purpose of that intake is to just understand your situation and your needs. And from there, we're making a couple decisions. The first is, are you currently safe to practice your profession? And because, as Robert mentioned, we have a duty to not only address the healthcare professionals' health and well-being, but also public safety. So we're making a decision about, whether or not this person is safe to practice. Also determining what we need to do to intervene, whether that is a referral directly to treatment, but most often it's a referral for a comprehensive evaluation that will help us determine, diagnostically if someone has a substance use disorder, and if so, what treatment is recommended, and are they currently safe to practice or not? And if not, what things need to happen. When we're talking about substance use disorder, usually that's treatment and some stability. So as Robert mentioned earlier, most people come to us in the later stages when their disease has progressed to the point where we're seeing impairment in the work setting. And so for most folks, we'll ask them to withdraw from practice while they undergo treatment. And once they complete the initial stages of treatment, they'll begin monitoring with us. And monitoring, as I mentioned earlier, looks like, ensuring that they're following through with treatment recommendations, random testing, attendance at support group meetings. I kind of describe it as we're kind of like forcing people to put themselves first, because most of us, and I think healthcare professionals, put ourselves last. And so it's really a way of prioritizing your health and making it the priority. Sometimes people don't see it that way at the beginning, but they do over time recognize the need for that.
And so what's a typical duration of time that you monitor someone? Is it set time, or is it dependent on the treatment recommendations for that person?
Monitoring on our program is for 5 years. And the reason for that is, and Robert, you could jump in here and speak to the research a little bit more, but the research that has been done with, I think, well, Robert, why don't you talk about the research?
So the current 5-year program duration is based on a fairly old study that was done more than a decade ago, which suggested that after 5 years of monitoring, that healthcare professionals who participated in our program or a program like ours would have 80% success rates. That is, that they would be in long-term stable recovery and they would be working in their profession. There's currently a good deal of research underway looking at some of the more kind of granular detail about what the secret sauce is there in terms of, is it the duration of treatment? Is it the monitoring paradigms that are used? Is it the duration of the monitoring itself? What are the critical variables? Can some people be monitored for a shorter period of time? For instance, if they have mild substance use disorder, if they perhaps don't have as many co-occurring conditions. So clearly there's more research needed, but at the moment, it's a 5-year program.
And the data is quite remarkable. I mean, coming out of that in terms of success and it's reassuring, and it makes us wonder why on earth we think we can, treat people for 30 days in a residential program and expect them to do well, right?
Right.
Yeah.
No, it's absolutely remarkable, and I think it speaks to the benefits of having really what is a recovery-oriented care system. Again, our program, we don't provide the services; we provide chronic disease management. And so when the disease is managed in a comprehensive, multidisciplinary way, outcomes can be extraordinarily good. And I mean, you're quite right. What if we were able to engage people with substance use disorders who were not healthcare professionals in programs like these? Could we enhance the rates of recovery? And I think the answer is yes. It's just that people's willingness to do that is also, diminished, right? There's kind of a sword of Damocles with somebody's professional license, in that, if they want to continue to work in their chosen profession, then participation in a program and developing long-term recovery is paramount.
What happens if someone's defiant or fails just because their substance use? What if? when someone is defiant? How do you manage that? What's your approach? And what if someone fails, like quotation mark, fails this approach? What's the next step for them if they don't follow through with the monitoring, if they don't show up for their drug testing, or they don't go to treatment as you recommend? Then what happens?
Well, I mean, Kelly, we try to employ motivational interviewing techniques, and we do have to impose sanctions at some point if someone's not willing to engage, because again, we do have to ensure that the public safety is protected. But we work very, very hard with people. I mean, initially it's about relationship building, right? And getting them to see that we really want a good outcome for them, that we will engage with them in such a way as to try to foster that. But there's an uncomfortable sort of balance there in terms of how do we do that and give people chances without jeopardizing either their health or the well-being of the people that they look after. And it's a delicate balance, and I know it keeps me awake at night. I'm sure it keeps Kelly awake at night too sometimes.
Yeah. Typically, we try to have therapeutic interventions. So as Robert mentioned, we're always looking at, the safety of the person and the safety of the public. And so we have concerns about that. We may ask someone to withdraw from practice for a period of time, undergo reevaluation, increase their level of care, those sorts of things. So we try to take therapy, have therapeutic interventions. But if we do reach the point where someone just refuses to do what's being asked of them and there's a risk to public safety, then at that point we have an obligation to turn their case back over to the division, which could result in public discipline. But it takes a lot. It really, those things don't happen unless someone is just unwilling to work with us. And that does happen sometimes, but the majority of cases, people are willing to take the steps that we ask them to take.
I think it's difficult too, because one of the sort of cardinal manifestations of substance use disorders is that, when we have them, we just don't see the equation in the right proportions, right? We just don't see the magnitude of the problem versus the magnitude of the risk. And so a lot of folks out of the gate really feel like this is a tremendous overreaction. But if you fast forward 2, 3, 4 years down the road, many times they look back and they're very grateful, right? Our program's really only been in existence for 3 years. And so we're just now kind of developing a group of people who
we're grateful.
Thanks for kind of pushing me a bit to do this. We have a lot of new people who still just kind of are not there yet. But
impairment at work, especially for healthcare providers, is often the last manifestation.
Yeah.
Of a substance use disorder, right? We'll let everything else fall apart.
Absolutely.
Until the very end. We hold on to work, which I don't know if that's just because we value work or it's because it's linked to our livelihood. But by the time it affects our work, we really are in trouble. It's a late presentation. And
absolutely. I mean, we are trained to show up and look good and despite just being crumbling on the inside, right? I mean, that's what our training teaches us to do. And so you're absolutely right. By the time somebody's disease is showing up at work, they have advanced disease. Kelly, I think you'd agree, right, that there are people who we've really worried would not ever kind of get this. And with perseverance and healthy boundaries, and that they're now back at work, leading healthy, productive lives.
Yeah.
Families that have come back together. And I mean, that's a beautiful and rewarding thing to see. But sometimes it's pretty hard work getting there.
I'm like, just give us 6 months.
Right.
Give it at least 6, and then
maybe 12.
Or maybe 12. Yeah. Depending on the person.
So when someone is referred to treatment, what treatment options are available to them? Historically, these professional health programs have been associated with more abstinence-based treatments, and MAUD and some of these other like medication-assisted treatment has not been available. That's what would typically, when I've treated patients who have been involved in these programs, that's usually some of the restrictions that have been placed on them. Now, granted, this was years ago and not this current program. So can you speak a little bit about that? Like, what specifically are they being referred to? Like, what kind of options? Is there anything that is restricted? What's available? And is that a barrier to people seeking treatment because they're going to be limited on what they're going to be allowed, not what we would normally offer as far as our other evidence-based treatments?
I think one of our greatest challenges is the initial episode of treatment, whether that be most of our folks need residential treatment. And traditionally, healthcare professionals have been treated in facilities with other healthcare professionals. And that's difficult because in Utah, there are no treatment programs like that. And so that means that in order to have someone participate in one of those programs, they have to go out of state, which is enormously expensive. They're separated from their families. It's very difficult. And many of these people will have lost their jobs and their health insurance. And so it's very difficult to insist that someone go to one of these programs. Now, I think we're able to be a little bit more lenient with healthcare professionals who are non-physicians in terms of finding them adequate treatment that is in state. But in an ideal world, we'd have everybody attend a treatment facility that had other healthcare professionals in it and had, importantly, therapists and a medical team that had expertise in treating this population, because it is a different population, right? That kind of goes back to what Paula was saying earlier, and just the fear and the shame and all of those things is amplified. There's a professional degree of fear and shame, right? That people really believe they should have been smarter than this, or they've done something that is unforgivably bad, and of course none of which is true. But after the treatment episode, people can use MAO in our program, and so there is, we've as long as somebody is under the care of a responsible provider who is prescribing MAO and other modalities, then that's okay with us.
That's great to know. And you brought up an important point there is also as far as cost. That can also be a burden, because I've also encountered this with clients that I've treated as well, that like you said, some of them have already lost their job and lost health insurance, and the cost of their treatment is on the burden of the professional. And some of the studies that I have read, I mean, we're talking $200,000 to $400,000 in treatment over that 5 years, as far as paying for monitoring their testing over that time, and residential treatment and all that subsequent care. It was interesting, though, because the study did say that the majority did say it was worth it, even though it was at a high cost. But that is something that is a barrier. That is a challenge. And I don't know how many times are you finding that is something that you're having issues with sometimes engagement?
The cost of initial treatment is generally $20,000 or more, and we're having but our participants are having more success in getting at least some insurance coverage for that. And then the cost of monitoring the urine drug testing may be as high as $3,000 to $4,000 a year, and insurance will not cover that. And I don't know that we've had anybody who has said, "Look, I can't participate in your program solely on the basis of this," but we're afraid that it just, we haven't heard that. We know it's a huge ask. And so we recently had a study that was done in collaboration with some public health students at Westminster. And out of that, one of the biggest barriers to participation is the cost of ongoing monitoring. And so Kelli and I have been speaking with healthcare organizations in the state, and starting to try to at least plant the seeds that, if you have an employee who's been a good employee and you want to retain them, what would you think about picking up some of the cost of evaluation, some of the cost of treatment, some of the cost of urine toxicology? And we're trying to think about creative ways to try to offset some of that cost, because it is prohibitive.
Mm-hmm. Yeah, it's an interesting issue. We have an episode with Melissa Chang on substance use in the workplace, and it's really fascinating to talk to her from an occupational medicine standpoint, in terms of the general public who have substance use disorder and how it affects workplace productivity and cost and hiring and firing, and what it takes to be a good place of employment in terms of substance use destigmatization and friendliness and a culture. And I'm glad to hear that that's something that's being worked on, because I'm not sure how friendly our own healthcare settings are for this kind of thing. So my question from that is, what about qualifying for FMLA or under the ADA in terms of that initial period of being taken out of work for public safety or to get well yourself? Does that apply for people?
Yeah. Unfortunately, as Robert mentioned earlier, most people, once they get to us, have been terminated. And so that's not an option. But for those who are still employed, because we do have some of those referrals, or maybe people who have been in the program and have had a return to use and need to step away and restabilize, they are able to access short-term disability, FMLA services, those sorts of things, but not so much when they've been terminated. Usually people will have a COBRA benefit for 30 days if they can afford the COBRA premium. And so it's definitely an issue, but those are some solutions.
And we've been working hard trying to make inroads with big healthcare organizations in the state to try to get upstream of that, so that before somebody, call us before somebody is terminated, and give us a chance to intervene with someone and get them treated and get them well so that they can come back to work for you. Again, this is somebody who has been, valued by your organization, who has worked with your organization for a period of time, and they can be valuable again, probably more valuable than ever before, right? And this is one of the only medical conditions I know of that people can get sort of weller than well, so to speak. Mm-hmm. And if they were a good employee before, they'll be an even better one now.
What do we do if we notice, not as an administrator or a boss, that one of our healthcare colleagues is probably experiencing a substance use disorder? How do we approach that? And how do we approach the other colleagues who may not be addressing it appropriately? What do we do? What suggestions do you have?
So I think that's a great question. We do get calls from employers on occasion concerned about a colleague, and the things that we hear from them are just, well, I'm not sure that there's actually a problem, and what if I'm wrong, or what if they get fired and they lose their license? And so my advice to people is a couple of things. Is that the most compassionate thing that you can do is talk to the person and try to understand what's going on, express your concern for them, let them know that there's resources and support available to them. The other thing is if, it's obvious, making a report to a program like ours, or even if you're uncertain, then we can reach out to the potential participant and talk to them about the program and try to understand their situation. One thing that I often tell people, because their biggest fear is this person's going to be mad at me, they're going to be upset with me, they're going to be angry, is just, that I would much rather have somebody be angry with me than to be dead. And that's the reality of substance use disorder, is it is a life-threatening disease. And so if we can start to think about it that way, and that, intervening is probably the most compassionate thing that you can do for somebody.
And people, although people have to have a substance use disorder to participate in our program, they don't have to have a substance use disorder to engage with our program. So let's say that somebody's just not themselves, and colleagues, co-workers, friends are worried about them, and they don't really know what the problem is. We can have an evaluation done that can help pinpoint the problem. Maybe it's not a substance use disorder. Maybe it's depression. Maybe it's grief. Maybe it's some other kind of life stressor. In which case, they don't have to have a substance use disorder. There are other kinds of help that we can direct them towards.
That's very valuable. I mean, especially with the incidence of mental health disorders in healthcare professionals, and we're not immune, certainly not. And we have high rates of depression, anxiety, PTSD, as well as some of the other mental illnesses.
As well as suicide, right?
Mm-hmm.
We know that suicide rates in healthcare professionals are 2 to 4 times age and income match controls. And albeit underlying half of those suicides is a substance use disorder, the suicide is absolutely epidemic in healthcare professionals. And so some of these problems neglected lead to death.
That's a very important point. That's excellent. What an excellent point you make too, that if they were a good employee, even in spite of their substance use disorder, imagine how much more well they'll be, and with the insight of and the compassion of this lived experience of having a condition that is very difficult to recover from for all the reasons. So what do you want our listeners to know about a professional health program? Like, what are the key points that you really want to know? And I think using this opportunity for advocacy too, which I hadn't really thought of, like what a great way to advocate to bigger organizations and systems. But is there any key points that we haven't talked about yet?
I think just the takeaways that I would want people to know is that I think oftentimes people feel like they're alone and they're the only person in the world dealing with a problem. And so I guess I just want people to know that if you're listening and you're struggling, you're not alone in the struggle, and that there is a path forward. That if you were to self-report to our program, we may ask you to do hard things, but things that are worth having are sometimes difficult. And if you take those steps, we see people have, amazing transformations, and we feel really honored to witness that. So just know that you're not alone, and that there's a path forward, even though it may not feel like it right now.
And that there's just nothing that is more important than your health. I mean, I think as healthcare professionals, we tend to think that we are the work that we do. But the fact of the matter is that whether we actually do this work or not, there's nothing more important than our health and well-being, and that there's always hope. No matter how difficult things have become, no matter what has transpired, there is always hope. There's a path back.
Well, that's so well said, and it's moving. So, thank you so much for saying that and for being there. So what, aside from people even people in Utah or around this country, we have listeners, actually quite a few listeners in Canada and Australia and in the UK. So I'm not sure if we can speak to their needs, but for listeners in the United States, where can they get help if they fall under this category of having a medical license of some kind and needing this kind of a program, and they want to self-report or now know they can? How do they access a program like this?
So every state will be different, but a place that they could certainly begin is at the Federation, the FSPHP, which is Federation of State Physician Health Programs. And on there will be a list of resources in their state of professional health services that are within their state that they can contact.
And also call me directly.
If you're in Utah, right?
Yeah.
Just call Kelli.
just call me or send us an email. So,
I mean, if I was in this situation, I couldn't imagine being in the care of two better people, honestly. So I would encourage people to do that. You'll be in such wonderful hands, and I guarantee that there's like-minded and like caring people in other organizations around this. Robert, it affects so many of us. Many healthcare professionals are living in the shadows for many reasons, and it's worth it.
Yeah. Thank you so much for having us.
Yeah. Thank you.
Thank you. Until next time. Hey, check us out at theaddictionfiles.com or email us at theaddictionfiles@gmail.com. Thank you so much to Ricky Valades for use of his song Awake. Check him out at rickyvalades.com.
entertainment and education purposes only. Hosts and guests are not responsible for any harm caused by information obtained from this source. As each person is unique, you are advised to seek the advice of your own healthcare professional to treat any medical conditions you may be having. Opinions expressed on the show are those of the Addiction Files and not of our respective employers.